Hi everyone, this is Mr. Neil Reiter, consultant audiologist and director of Clearwax. Thank you for joining me in another demonstration video of our recently developed WAXscope, which is due to be launched in early autumn 2022. So if you're an ear care professional who's interested in learning more and getting trained and purchasing the WAXscope, please do email info@clearwax.co.uk and we can add you to our mailing list to keep you updated as and when we have more information for you. So we have a patient who attended with bilateral, fully occluding soft and wet earwax. They recently returned from holiday and they of course were swimming and got water in their ears. So the water caused the wax to become soft, and the wax absorbed the water and expanded and exacerbated their symptoms because it created more of a blockage. And I'm just using our 4.25mm speculum here. So we've got 4 speculums. We've got the 3.5mm, which is our smallest one, the 4.25, which is what I'm using at the moment, which is probably going to be the most commonly used size specular. Then we have a 5mm, which is meant for larger ears, and then also a 5.75, which can be used for extremely large ear canals and mastoid cavities. And you can see the wax is quite sticky and soft, and that's because they had also been using some olive oil drops, but as mentioned, they had got water in the ear. So I discussed water precautions with the patient after I removed the wax. This last plug was a bit firmer actually, and initially when attempting to get a suction grip, I inadvertently pushed it further in with the suction probe. And you can see there's an opening there through the wax, so the eardrum is visible in the distance. And this patient has had previous grommet surgery as a child, so you'll see once we remove the wax that they have got some tympanosclerosis. I think they also mentioned, I think it was the left side, they had a previous tympanic perforation which is healed, and if memory serves me correct, you will be able to see the outline of that perforation where it's healed. So again, this wax has just adhered itself to the roof of the ear canal. You've got loads of skin adhesions there. There's a few hairs as well matting against the wax, but we're just bringing this through. And you can see with the WAXscope, it's not only the great clarity and focus, but also the magnification. I was speaking to someone today who was interested in the WAXscope, and they've been watching a few of the videos and they're really impressed by it. And they mentioned that they are using another device, but they are I think it was loops that they were using, and they've tried several different magnification techniques, visualization techniques. But what impresses them about the WAXscope specifically compared to the rest is that it's the magnification and the change of focus, how easy that is, and also how clear the instrument looks in the ear, because they feel that's really important to them. So when you're removing wax of the canal wall, for example, or near the eardrum, being able to see the instrument very, very clearly is going to obviously help you remove that wax. You can see the tympanic membrane there, so you've got the inferior posterior quadrant, you've got tympanosclerotic, you've got some bit of wet wax just at the entrance here. So I'm just mopping that up. And then we're going to move on to the patient's left ear. So again, we're just dilating the ear canal using the speculum, and we just adjust the focus. And you can see that's come in view now. Similar to the patient's right ear, it's very wet, soft, and they've been getting water in this ear as well. And in addition, they've been using olive oil drops. So I've just got a suction grip here. I just want to, you can see when it's soft like that, the suction probe indents itself. You've got an indentation there in the wax. So I'm probably just going to go a bit lower and try to tease this upwards. And see, we're just lifting it up, and then got the first plug there. As you go more medially, the wax became a bit firmer, so it's a bit easier getting a suction grip. You see it's quite dark, it's been there for a while, so it's oxidized. The patient had mentioned that it has been troubling them for a while, but they're just putting it off because it wasn't causing them a massive mischief until they went on holiday, and as I mentioned, when they went in the swimming pool, they regretted doing it so afterwards. So I always advise my patient, we want to avoid water entering the ear in the first instance. So whenever they're exposed to water, say in the shower, in bathing, swimming, where possible. I mean, I'm careful. I don't put any water protection plugs or sprays in my ear, but just very careful not to allow any water in. It can be a bit more tricky and difficult for others. Say women, for example, longer hair that goes over their ears, it's more likely if the water can enter. So you can use foam or silicone plugs or swim putty, or there's many sprays out there, water repellent sprays. But I'm always, instead of the sprays, I would rather avoid the water entering in the first place. It's that time of year where we're seeing many ear infections. I think I did a clinic of 10 today. I think 4 of them were ear infections, swimmer's ear, and also I had a couple, so I had one with otomycosis, Aspergillus niger. So it's that time of year. So we've removed all the wax, and again, we're just going to set the view of the eardrum. You can see it's tympanosclerotic, and just under the umbo centrally, there's a bit of a thinning of the eardrum. So I suspect that's where the patient's tympanic perforation previously existed, and it's since healed. Well, I hope you enjoyed that video, guys. And if you are interested in the WAXscope, please do email info@clearwax.co.uk. Thank you. Bye.